Our panelists for the session are Professor Leanne Robinson, Senior Principal Research Fellow, Head of Vector-Borne Diseases and Tropical Public Health at the Burnet Institute. Our next panelist is Dr. Thắng, Chief of Epidemiology Department, National Institute of Malariology, Parasitology, Entomology, Ministry for Health, Vietnam. And we also have Dr. Siv, Program Manager, National Centre for Parasitology, Entomology, Malaria Control, Ministry for Health in Cambodia. Our moderator for this session is Dr. Caroline Lynch, Regional Advisor, Medicines for Malaria Venture and Co-Chair of APMEN Vivax Working Group. Thank you, ladies and gentlemen. We're going to get straight into it. And as the panel is taking stage, I'd like to announce that we expect the Prime Minister to attend the end of the session today. We expect the Prime Minister to arrive around 5 p.m. to make closing remarks. So it's imperative that we have the panel discussions, we round up discussions, we give time for question and answers, but really be mindful of time because we want the final session to be really wrapping up in anticipation for the Prime Minister. And there will be a procession of sorts, so we really need to kind of have those discussions closed off. So without further ado, I'm going to hand over to the chair, and thank you.
Good afternoon, everyone. Welcome to this session, Essential Health System Functions for Effective Current or New Tool Utilization. I'm honored to chair this session from Korea, South Korea, not North Korea. Don't mix up. If anybody have a chance to meet North Korean people or any connection with them, please ask them, how about their malaria condition? Actually, we don't know. We don't have any communication with them. However, now our situation is so bad. So if we have any chance to communicate with North Korean people, actually maybe we don't have anything. We cannot do anything. Because the political issue is perfectly covered our malaria elimination issues. So anyway, back to this session, essential health system functions for effective current or new tool utilization. We'll explore the critical role that health system functions play in the effective use of both existing and emerging malaria tools. To success of malaria control efforts, it relies heavily on the seamless integration of these tools into health system. This includes robust infrastructure for storage and distribution, efficient supply chain management, and a well-trained healthcare workforce capable of proper application and monitoring. Strengthening these health system functions enhance our capacity to deploy malaria tools effectively, leading to significant improvements in malaria control and elimination. Today's session aims to emphasize the importance of optimizing health system functions to maximize the utilization of malaria tools. We'll highlight strategy to strengthen key components of health systems and provide actionable insights to enhance the effectiveness of our malaria control and elimination efforts. Fortunately to me, this session has a co-chair, Dr. James Kelley, who will provide the key insights on this subject of this session. And Dr. Caroline Lynch will be the moderator for our session. We also have some panelists in here. They will share their expertise on various aspects of health system functions. This panel discussion will search into the essential components of the health systems that are pivotal for the effective utilization of malaria tools. The panelists will discuss policy changes, health worker training, and patient access, stock availability, and case management coverage. They will also explore the latest tools emerging from the research and development pipeline the challenges associated with the health system functions and strategies to increase their effectiveness. Our goal is to provide actionable insights to optimize malaria control efforts within existing health system framework. Thank you for all of being here. I am confident that the insights gained today will be invaluable in enhancing our malaria control and elimination strategy. From now on, I hand over to our co-author, co-chair, Dr. James Kelley, to provide his key insights in this session.
Good afternoon, ladies and gentlemen, distinguished leaders, and esteemed colleagues. It's an honor to be here today with my co-chair, Dr. Lee from Korea Disease Control Agency, and experts on the panel. It's essential to recognize the remarkable progress made towards global collaboration and innovative tools, but indeed a gap remains towards effective adoption and implementation of global malaria policies and recommendations at the primary healthcare level. Bridging this gap will require a multifaceted approach. I would like to mention 5 important strategies to consider for effective adoption and implementation of global policies and recommendations to the primary healthcare level. First, strengthening partnerships and collaboration. Effective and rapid policy adoption starts with strong partnerships. By fostering and indeed maintaining strong collaboration between governments, international organizations and donors, research institutions, and private sector, we can ensure that the latest tools and recommendations are shared swiftly and efficiently. Second, streamlining the regulatory process. One of the main hurdles in adopting new malaria tools is the lengthy regulatory approval process. To expedite this, we must harmonize regulatory standards across countries and regions. Establishing mutual recognition agreements and standardized approval pathways can significantly reduce delays, ensuring that effective tools reach those in need more quickly. Third, enhancing data-driven decision-making. We are living in a new age of AI, like it or not. Robust data systems are crucial for tracking the implementation of malaria tools. By leveraging digital health technologies and data analytics, we can monitor the uptake and effectiveness of interventions in real time. This allows for rapid adjustments and ensures that national policies are based on the latest evidence and best practices. Fourth, building capacity and resources. Adequate training and resources are essential for the successful implementation of new tools at the primary healthcare level. Investing in capacity building and providing the necessary infrastructure and financial resources will enable countries to integrate new recommendations into their national malaria control strategies. Fifth and finally, engaging communities, as discussed a lot already during the last day and a half. Community engagement is vital for the successful adoption of new tools. Policies should be designed with input from local communities, ensuring they are culturally appropriate and widely accepted, particularly with this last comment given in the last session about cultural and appropriateness based on cultural beliefs. Community involvement can drive awareness, acceptance, and proper use of malaria interventions. One example from WHO that I'd like to share is the process of generating guidelines and recommendations on the use of tafenoquine and companion G6PD point-of-care tests in the fight against Vivax malaria. This process is well underway. Following the inclusion of tafenoquine and near-patient G6PD tests in the WHO pre-qualification lists and the release of new guidelines, WHO will convene a technical consultation this year to develop a field guide on the case management of Vivax, providing practical guidance to support the implementation of the new recommendations on the ground. After which, the adoption and implementation at the national level will require as mentioned in the strategies, coordinated multi-sectoral engagement, strengthening partnerships, streamlining regulatory processes, enhancing data systems, building capacity and engaging communities. Through this, national programs will be able to transform these recommendations into action and move closer to malaria-free world. Thank you.
Great, thank you. Should I shout? Yes. It's working, okay, great. Thank you, Dr. Lee. Thank you, Dr. James. It's not working. Hello? Great. It's microphone. It's just gone. No. Okay, thank you, Dr. Lee. Thank you, Dr. James, for the comments. I'm both moderating the session and presenting, and so let me give you the format. Professor Leanne is going to talk about the new tools that are emerging from the R&D pipeline. It's a really exciting time, and I'm looking forward to hearing what new tools are coming out. I'm going to take the place of a panelist who couldn't actually make it today and talk about the health system that those new tools will go into. And then we're going to ask our colleagues who are at the cold front of all of this to comment on the challenges and potentially the solutions that they've found in introducing tools into health systems. After that, we'll have one question for each of our panelists, and then we're going to go to the floor for a Q&A session. So please gather your thoughts and be prepared to ask the panelists some questions. And then Dr. Lee will finish with a summary of the session. So I'm going to hand over to Professor Leanne Have we got Professor Leanne's slides ready?
Thanks very much, Carrie, and thanks very much to, firstly, the government of Papua New Guinea for, no, that's not the right slide set. Sorry. For hosting this event, and to APMEN and all of the effort that's gone into the organisation. I'm delighted to be here with you all and to have the opportunity to be part of this panel. As Carrie said, I've been asked to talk about the new tools that are emerging from the pipeline of R&D that will be most relevant to this region, to then sort of complement the perspectives that will come from other panel members about how we can best ensure utilisation of those tools to maximise effectiveness together with current tools. And so I've deliberately kind of called this new approaches, because I think it's really important that we've heard a lot over the past day and a half that it's really not just about the tool. Effectiveness comes from the way the tool is used and uptake of the tool by health workers and by the communities, and that's how we get maximum effectiveness. So throughout, I want to try and reflect on how we can be thinking about that process as some of these new tools emerge from R&D and into those implementation studies, so that we can shorten the timelines as much as possible between these tools becoming available and the evidence that countries need for implementation being available. Next slide, please. And I think it's also been highlighted that we don't want innovation for innovation's sake, integration for integration's sake. I think we also don't want new tools just because they're new. So what do we still need to achieve elimination in our region was how I wanted to start. And I think we can all agree, and we've heard like a little bit about this over the last day, that we still need new drugs and new drug combinations to tackle resistance and the continued spread and potential emergence of different forms of resistance. We also need simpler and more effective treatment and preventative approaches that can be more easily integrated into the health system. And what I'm going to focus on most in the next few minutes is what I think is the most important thing for this region, and what I've heard from most of the sessions we've had, particularly those that have included our ministers and program managers from endemic countries in the region, is new approaches to tackle Plasmodium vivax malaria, which remains the major challenge for meeting those 2030 elimination targets for this region. Next slide, please. So in terms of tackling resistance, I think we're actually pretty well set up, and I think we also have the great stewardship of MMV in terms of ensuring a pipeline of new anti-malarials to tackle the problem of resistance. We have multiple first-line therapies that provide a greater variety of drugs in circulation, allowing programs to cycle these drugs through and reduce the risk of the emergence of resistance to any partner drug, or tackle that emergence of resistance when it does happen. We also have triple dose ACTs, where that third compound protects against resistance. And we've also got a whole pipeline, and Dr. Michael Charles included that slide yesterday in the session about the pipeline of new non-ACT combinations that are currently in trials, and provide a simpler dosing regime once a day for 3 days against multiple stages of the parasite. And these could really be a game changer as they become available as well. Next slide, please. I think it's also really important when we're thinking about new tools and new approaches that we look at some of the preventative approaches that we already have in place, particularly in many sub-Saharan African countries that are working well, and what aspects of those could potentially be adopted in a fit-for-purpose way in settings where they're appropriate. So chemoprevention strategies like intermittent preventative treatment in pregnancies is already policy in many countries in this region. But other approaches like intermittent preventative treatment in infancy and seasonal malaria, chemoprevention are not, and there are things that could be thought about and lessons that could be learned where we've seen efficacy of these interventions in other settings. We already have mass drug administration happening in certain countries in terms of interrupting P-falciparum transmission and focal MDA to really get to that end of the line in terms of elimination. But we also know there's problems when we think about community and community acceptability with MDA. There's needs for new approaches that could actually enhance or achieve more with those sorts of approaches. And we've mentioned vaccines and the fact that we now have 2 approved P-falciparum vaccines, but also the limitations that these vaccines are not fit for purpose for this region, and that we still have a major gap in terms of no licensed approved P-Vivax vaccine. But what we do have to potentially slot into some of these chemopreventative approaches are monoclonal antibodies, and passive immunisation of monoclonal antibodies through direct administration of functional antibodies could potentially really overcome some of the limitations associated with vaccination, where we have to wait for that protection to kick in, by providing immediate protection. And the simplified dose regimes associated with monoclonal antibodies and long-acting injectables could also really help improve the coverage and adherence issues that can be associated with current chemoprevention approaches. So again, there's some new things to think about there. Next slide, please. But where I really want to focus, again, is the new approaches to tackle Vivax. And I'll briefly start with why do we need new P-Vivax tools. I think most of us in the room are aware, but it's really because the malaria control tools we have at the moment are really largely falciparum tools. They haven't been designed with Vivax in mind, and we really haven't got a clear Vivax elimination strategy. But we need these new tools because hypnozoites continue to contribute 80 to 90% of infections, especially in high Vivax burden countries like Papua New Guinea. Hypnozoite carriers can't be identified with current diagnostics, and the vast majority of infections are asymptomatic, submicroscopic, and escape detection through the current way that we diagnose and treat malaria. It also transmits very efficiently early in the infection and at relatively low density. So without better approaches to more effectively attack this hypnozoite reservoir, Vivax elimination is going to be very slow and difficult to achieve. Next slide, please. Thankfully, though, we do have some new tools, and many of those, and Dr. Kelley just referred to the way that tafenoquine and G6PD is moving through the policy process to be ready for implementation, will provide us with the opportunity for improved case management. There's also evidence around universal radical cure that I'll briefly touch on. And in the next couple of years, there's several next generation PFPV RDTs with 5-fold higher sensitivity for detecting PF and PV that could really, in combination with more effective radical cure actually maximise the impact that we're going to have on Vivax transmission. And then I want to briefly touch on a new approach to target the hidden hypnozoite reservoir that exists beyond the health facility in communities where there's asymptomatic infections, hypnozoites in the liver, people not coming to facilities because they're not unwell, and a possible approach we could have in elimination areas where really you're ready to throw everything at eliminating Vivax, and what approaches we have to do that. Next slide, please. So starting on the case management, I think, we've heard quite a lot of people talk about the desire they have within their country program to move towards G6PD-guided high-dose primaquine or tafenoquine radical cure. And I think we're really almost ready to do that. There's a strong body of evidence now that in individuals with more than 70% G6PD activity, 7 days of 1 milligram per kilogram per day primaquine is very well tolerated and non-inferior to 15 days of the 0.5 milligram regime. And there's implementation research ongoing in PNG, Indonesia, Vietnam, Ethiopia and Peru under the UNITAID-funded PAVE program that's really generating the evidence needed to guide national policy and scale up. And since we're in PNG, I just want to really briefly highlight the PNG team here, led by Dr. Moses Laman and Dr. Maria Omekais, who are leading the work in PNG. Next slide, please. Where the team are really not only assessing, next slide, please, the feasibility of implementing high-dose primaquine for Vivax malaria, but also kind of establishing, the evidence that's going to be needed to ensure integration into the health system here in PNG. So the team are doing point-of-care quantitative G6PD assessment that will guide whether or not patients receive PQ7, PQ14 or 8-weekly primaquine. They've also developed improved Vivax-specific patient counselling tools and processes and are undertaking social science research to understand the acceptability and factors that can really maximise treatment adherence. We're also piloting for the first time in PNG and Indonesia, where these studies are happening, a community-based clinical review at day 3, and trying to see whether this could work through the village-based malaria home-based management system as a way of encouraging adherence and facilitate detection and management of adverse effects of treatment, providing, again, the evidence that's needed for scale-up. And at the same time, really working closely with the National Department of Health's Pharmaceutical Services and Standards branch to strengthen pharmacovigilance. Because with high-dose primaquine, it's a really nice way of ensuring this system is strengthened, such that if in the future Papua New Guinea, other countries would like to consider tafenoquine, which really requires, in terms of its registration in country, a very strong pharmacovigilance systems and standards to be met, then we're on that pathway in terms of this sort of work with high-dose primaquine. Next slide, please. There's also studies, as I mentioned, in Vietnam and Peru and Ethiopia that are exploring similar feasibility studies for tafenoquine. And there's also tafenoquine dose optimisation studies and trials of higher dose tafenoquine that are commencing. Next slide, please. And as I'd mentioned, there's also some really excellent evidence around the benefit of universal radical cure. So this is giving radical cure to people with clinical malaria, whether it's P. falciparum or P. Vivax. It's highly relevant for co-endemic settings where we know that falciparum patients after treatment very often within the first 1 to 2 months have a recurrent Vivax infection. And a trial led by Kamala Thrimer showed that G6PD normal patients with uncomplicated P. falciparum malaria, and I can't actually see, had a 5-fold reduced risk of subsequent P. Vivax parasitemia compared to those that just received blood stage treatment alone. So there's really a strong potential for this kind of approach in settings like PNG, Melanesia, where we have co-endemic P. falciparum, P. Vivax, Malaria ovale, and irrespective of the species causing your clinical malaria, your patient will benefit from receiving radical cure, and we start to reduce transmission of Vivax. Lastly, last slide, is consideration around how we get these tools beyond the actual health centre, because the continued challenge for Vivax elimination is targeting those hidden hypnozoite reservoirs in communities. Next slide, please. And as mentioned at the start, mass drug administration that includes an effective anti-hypnozoidal drug could achieve this. And, I think we have a great example in China where MDA with chloroquine and primaquine did achieve this. Whereas if we consider mass screen and treat approaches with microscopy or even highly sensitive PCR, we see in the graph at the bottom that we don't have the same impact compared to MDA. The problem is, do we really want to be treating everybody with an acetaminophen that has potential for adverse events when only perhaps 25% of the people need this? So we really need a way to identify those people that are harbouring the hypnozoites. And next slide, please. And so the way that that's currently being addressed at the moment or explored, the potential, is through a Gates-supported VISPA consortium and the use of serology to really address this diagnostic gap, where individuals with Vivax infections within the past 9 months obviously have a very high probability to have hypnozoites in their livers. And so by measuring the antibody response that's indicative of past recent exposure, we can identify individuals who have this very high probability of having hypnozoites and a likelihood to relapse. And so, next slide, please. The team at Heeil and through this VISPA consortium have done this, and there's now a highly sensitive and specific PV serodiagnostic assay that has 80% sensitivity and specificity for classifying recent infection, and even higher sensitivity and specificity in a trial in Indonesia for actually identifying individuals likely to relapse. And so this is a very promising tool that is going through development. The VISPA consortium, next slide please, has been working very closely with WHO around use cases and preferred product characteristics, and these are summarised here, and for those interested you can use that QR code and take a look at the PPC. But there's really a strong groundswell, I think, of support now across programs in the region and WHO, particularly around use case 1, being the using this test to diagnose relapse risk to guide radical cure, in elimination areas, being able to screen individuals and provide radical cure to those that are seropositive. Could be a really effective strategy towards elimination. Modelling studies that the VISPA consortium have done using data from Brazil show that in addition to strengthened case management, 4 rounds of serotat is sufficient to achieve Vivax elimination. So I won't go through this in detail because I feel like I'm over time. But just to summarise, I think those gaps that I identified at the start, I think we do have new tools and approaches that we can think about. But importantly, I think it's about in trials or implementation studies, ensuring we're not just assessing the efficacy of the tool, but also understanding community perspectives, health system barriers, enablers to the potential introduction of these tools, generating the evidence that's needed for implementation. And so I just want to finish actually by I think really highlighting that it is through coordination, local ownership, sharing of resources and a genuine partnership way of working that these studies can be done in a way that ensures the health system is ready for adoption and can, and I know Carrie's going to talk more about this, but can actually overcome some of the barriers associated with introducing new tools. And I want to join with others in really acknowledging and paying my condolences on the passing of the late Mr. Larry Makita, who really, under his leadership, together with Dr. Moses Laman and Prof. Willie Pommet, has allowed this style of implementation research to come about in PNG, where key knowledge gaps and new and emerging research questions are asked as these new approaches are actually studied in the country. And the increasing recognition of the importance of qualitative research being undertaken alongside trials or implementation studies to really ensure we understand those community and health system perspectives and can develop approaches that can be sustainably embedded within health systems. Thank you.
Great, thank you, Leanne. And I think everyone can admit that that's an exciting pipeline. I know that Dr. Michael also presented the pipeline in the RBM session earlier. We're at a very exciting time. But I'm going to go on and talk about something that actually Helen referred to the other day in her panel discussion. It's not just about tools, which might sound slightly strange coming from someone who works with MMV, whose mandate is to develop new tools. But I work on the access team, and we put a lot of thought and effort into trying to figure out how to get not just the tools that MMV develop, but any complementary tools into this health system so that we can improve coverage of malaria case management. So I'm going to talk about pushing the processes to implement new tools effectively in health systems. So first of all, can we go back one, please? So first of all, I'm going to just go through the pathway of following a new tool from just outside the R&D pipeline as it falls out and down into the patient's hands. And then we'll talk about some solutions around pushing the process. So if we go to the next slide. So this is a very simple diagram of the pathway that tools take to get into patients' hands. And it starts for a lot of countries at the global level. If they're reliant on global funds, PMI, then these global processes are quite key because they involve the pre-qualification of new tools and then the development of policy recommendations from WHO GMP. Those then drop down to the national processes, which then also require regulatory approvals and a policy change at the national level. Those top two pieces, can we just stay on that slide? Those top two pieces for me denote a time issue, a delay in getting new tools into patients' hands. The bottom part, the national policy implementation, is more about a decay in effectiveness that we see in health systems. And I'm going to go back to what Professor Moses was talking about in an earlier panel. I think he explained it quite well, that there's an opportunity to decrease these steps of decay in a health system, even with the current tools, and before even thinking about new tools. But first of all, we have to think about whether a patient can actually get to where case management is available, be that at community level or within a formal health system. Then whether the tools are there, and I've heard in the panels yesterday talking about the right tool at the right time in the right place, but also the right people in the right place with the right tools. And all of that coming together can sometimes be like getting the stars to align. And finally, we have to think about the capacity of the health workers to use those tools. And all of that together influences whether a patient will get effective care to clear malaria parasites from their systems. So if we go to the next slide, we know there's not much literature or research on this area, unless we've missed some, but we know that it takes between 6 months and 5 years, possibly longer, to move through those global and then national level processes. It's depending on the tool, depending on the priorities. But when I think about the timeline, or the new tools coming out in 2028 and the RBM big push, and I think about this timeline, then it's clearly something to be done about the processes at those levels to ensure that we get things done quickly. Then if we go on to the next slide, and we drop down into national policy implementation, this is just an illustrative example, but these figures haven't changed much in about 10 or 15 years. This is based off some work originally done by Bhargavi Rao, who I had hoped would be here with us today, but unfortunately couldn't make it because of norovirus. But she kind of laid out this effectiveness, this stairways of effectiveness. And when we look at the data, we see that this is a pretty solid figure that doesn't seem to budge much. Around 70% of patients can access healthcare, whether that be the public or the private sector. So already, we can imagine that some of those cases are malaria, and they've already missed out from getting treatment and getting parasites cleared. And in the context of elimination, we're already losing in some respects. When patients get to a facility, whether there are diagnostics available with the treatment available at the same time is highly variable across the Asia-Pacific region. We don't have a huge amount of data on it, but that can range between 24 and 90%. So if we think again about the cases that we potentially miss treating because of stock availability, then we've got a severe problem in some areas of the region in getting to elimination. If we think then about the capacity of health workers, this indicator also seems to be stubbornly low, and it's also difficult to get data on it. But if we look at service provision assessments and more broadly at health worker capacity, sometimes in facilities, maybe 50% of health workers are trained in the use, in the national treatment protocol, say, of a new tool or of a tool. And all of that can lead to pretty low coverage of effective malaria case management. I just want to say, when we did a prioritization exercise for the Vivax working group in this region a couple of years ago, key areas that came up for national program managers was, first of all, training and supervision. We need to have effective training and quality training. Came out as the #1 priority, and I was pretty surprised at that at the time, but I'll go on to talk about that in a second. And the second priority was whether health workers had the capacity to use new tools. And Leanne has spoken about having simple tools. And I think that rings a bell because, when we think about a G6PD test, it's more complex than an RDT. And I don't know how many of you were around when the RDTs were introduced. I remember being in East Timor at the time. That wasn't an easy tool to introduce in the early days. We have papers saying, how difficult it is and the challenges with just a simple RDT. So now we think about a G6PD and a whole new test in the patient pathway. Then we are making things more complex for health workers, and we need to give them support. If we go on to the next slide, I'm going to just do not quite a deep dive, but a quick view into training. This is not a sexy topic, especially not after a lunchbox at lunch and a longish day, but let me give you a couple of slides on this. We know that there is strong evidence that health worker adherence to treatment protocols leads to higher patient quality of care. There's strong evidence for that through a pretty rigorous systematic review by Rowe et al. If we go on to the next slide, that probably justifies why millions of dollars is invested in training. I couldn't actually ever find a figure as to just how much is spent on training year on year, but I think we can imagine that it's annually quite a significant amount of money between, say, global funds and USAID. However, there's very limited evidence to show us that training is leading to higher quality of care for patients or even higher health worker performance or adherence to treatment protocols. So we have some studies showing that training did not improve quality of care, and there's modest effects for training alone in improving health worker performance. If we go to the next slide, my question and my original title to the session was, are we insane? We have these really exciting new tools coming out. Are we insane to put them through the same health systems and keep the same processes and expect a different result? Einstein would say we are. I'm going to be more optimistic than that and say we can fix things. So if we go to my next slide. I think there are a few things that can be done and are already being done in a few of the countries across the region. There's process innovations, which James mentioned earlier on, and regulatory reliance was done with the Australian TGA and the Thai FDA for Tefinaquin dossier in Thailand to try and share dossiers between regulatory agencies to quicken the processes. So, you're not reinventing the wheel every time for each regulatory agency. There's streamlining of policy recommendations and pre-qual, which WHO GMP had been piloting and is underway in doing. I think we could consider looking at the amount of work on national programs and the level of quality of training. We could consider outsourcing training to known good training research institutes or training institutes who can teach not only the technical content, but teach how to teach. Because often we can't get to training everybody in a facility, we have to rely on health workers to train each other to be able to use tools. We can monitor not just that activities have taken place, but monitor for quality. For example, I'm not sure of any countries that have a database on trainer competency. After they've been trained, do we know whether that knowledge has passed and that they're able to competently train further on down in the cascade of training that happens? We can set competency expectations. So rather than an indicator that says X number of health workers were trained, but what proportion of health workers were trained so that they achieved over 90% in their post-training competency? We can get ready for implementation earlier, and Leanne alluded to some of the feasibility studies that are being done with Vivax radical cure, but we can take some anticipatory action. Thailand have done a fantastic job of integrating pharmacovigilance into their Vivax radical cure training now as a result of the Arctic survey. So they bring someone with them from the pharmacovigilance unit when they're doing training. I know that Cambodia have done something similar in trying to work more closely with DDF to their regulatory and pharmacovigilance agencies to incorporate pharmacovigilance. So it can be done. And then through staged implementation, we can learn a lot more quickly about what things are going wrong. I think we can also provide far more scaffolding to new tool rollout. Oftentimes, the policy is passed, the training materials are done, the training is given, and then the tool is just allowed roam wild into the health system almost. And then the routine supervision, which in theory happens every 3 months, given to health facilities, doesn't happen because supervision is a softer intervention. But actually, more supervision is needed more intensely at the start of a new intervention, especially when you've got something that's relatively complex going into the health system. So monthly supervision over the first 9 to 12 months, depending on the capacity of the health system, could help in new tool rollout. It's a limited kind of intense supervision. That's something that we're trying in Pakistan at the moment. And alongside that, we've got qualitative data collection to try and understand if something's going wrong, why it's going wrong. And I think to Leanne's point, that qualitative monitoring, qualitative evaluation is much more required in our health systems. So I'll stop there with some of those solutions, and I look forward to hearing some of your questions to our panelists. But thank you very much. Okay, I'm just going to take a position over here. I am going to ask Dr. Thắng and Dr. Siv, could you give us your perspective on health system challenges when you're dealing with case management of malaria, and specifically, I guess, Vivax, given your two country contexts? What challenges have you faced, and what solutions have you identified to deal with those?
Good afternoon. Thank you, Gary and Professor Lynn, for a very informative presentation. We always expect and eager to have the new thing, the new tool, especially man. But with the existing tool, we already roll back malaria in many areas. But the remaining is really challenging for malaria elimination. Then we put a lot of hope for the new tool can change the situations. When we have the new tool and we have to face with several hurdles. The first thing, not only in Vietnam, but also in the other country, when we are applying new tools like G6PD test and new drug and so on, and today MDA, we need resources. Resource here, I mean that we need financial support, for purchasing things, for training staff, for supervision, for maintenance. And the other resource, I mean the human resource, personnel. When we apply the new tool, then sometimes we need additional staff or the current staff, but with more work. We have to train them, and they already overload of work, and they have to responsible for the new activity. So the constraint about the resources. But the other thing, we also have the technical issue. For instance, like the compatibility. Is it the new tool comparable with the existing system? And also, sometimes we think about the safety and privacy of the new tool for the patient, especially for malaria patient, when we do G6PD test and so on. And the other thing we also have to overcome, that is organizational issue. Do we have the advocacy? Do we have the leadership? If we don't have the leadership, then we don't have the financial support. So in the meantime, we also have to do the communication for the policy maker and also for the health staff in order to have clear impact of the new tool. What is the benefit of the new tool? And how quickly we can apply that to eliminate malaria. So I think the other, I also would like to mention here is from ourselves. Sometimes people are very conservative. They don't want to take the new tool, the new things. They said, no, with the current tools, already very good, it's going fine. Why now we overload the work? Why we need to change the new tool? So it takes a lot of time. Yeah, we also have organized many meetings to convince the health staff that is an effective tool. And we learn from experts and from neighboring countries in order to persuade our health staff. The other thing we also have to overcome is the usability. Is it the new tool friendly use or not, easy to use or not? For instance, like if we implement G6PD testings, and we need several training for people can take it off. But sometimes for 1 or 2 months, if we don't have the refresh training, they forget, and we have to train again, even online. So, yeah, I think that is some obstacle we quite often to face when we apply the new tool. In our country, recently we go to the last mile of elimination. So we need to facilitate the process, and then we need to apply the new effective tool. But not always happy. Sometimes we also have the challenges, and we need to overcome. Thank you for your attention. Thank you.
Thank you, Chair, and thank you, the esteemed audience. I will answer the question of what is the health system challenges in terms of the PV treatment or elimination. I only just talking about the Cambodia context. Currently, Cambodia situation is still only PV and others non-PF, like P. Malaria and PK. So no more PF in the country since January this year. What is the challenges of the health system for PV treatment? We know that in the country, more than 60% of malaria cases has been captured by community. 40% is receive treatment at health facility. With the current tool, the community don't have ability to treat P. Vivax. All P. Vivax malaria need to be referred to the health facility for treatment because they need to do the GCPD test and further on provide a capsule. The challenge is GCPD test cannot perform at the community level due to the no cold chain preserve the test and so on. It's not really a technical problem, but there is the tool themselves problem to be preserved in a proper place with the cold chain that communities don't have that one. So as current situation right now, Cambodia, only the 60% of PV malaria had been received treatment. 40% only receive treatment ACT, but not radical cure, due to the challenge of the GCPD test's availability. So I bringing with the new tool here, I heard that the presentation has been shown about the PV serotat that can be extend more for sensitivity. Now, before I say that, I put in the bracket that everybody know that PV asymptomatic is high, very high. But when we analyze in the country, only PV with the symptomatic. Because when the patient have a fever or something, they go to receive or diagnosis at the health system, so we know that they get PV. But there is a lot of PV asymptomatic disease going around that we not detected in the currently. So with the hope of the serotat that have more sensitivity, we can capture more hypnozoid that's thrown around by use this to screening people. So we have ability to provide treatment more people in terms of the PV's hypnozoid. And also, I'm not, because in Cambodia it's not implemented serotat yet. So I don't know exactly the serotat can be implemented at the community level. These are also one of the challenges. But however, if serotat has been so the efficacy as promising, like the presentation had been shown, at least some strategy has been switched to that for our strategy. You know, currently we do the active case detection and treatment surround in that case by using the current RDT, that sensitivity and specificity is not high compared to serotat as I expect. So we can replace by using that RDT, by using serotat, we can capture more the patient. So by include this into the current strategy as the national program have. And beside on that, not only the rearticulate detection and treatment, we can replace the TDA, target drug administrative, that currently have been implemented for PA malaria. But for PV, we still discussion, thus the target drug administrative should be further implemented for PV species. So if serotype come out, and this is more better, then we can use this, because treatment of radicaccio or Vivax is not simple as PA malaria. We need to provide treatment at least 7 days with the primaquine. But later on, tefanoquine or some new drug has been come out. We are not done implement yet. So currently, I have collaborate and propose with MMV, and hopefully that we can implement the pilot of the serotype and also some chloroquine MDA in the country soon. And 6 months along the way or 8 months, we will have good evidence, and we can consider to apply this as our strategy, or we can scale up the whole country for this. This is a challenge for PV in the country right now.
Thank you very much. So I'm hearing from Dr. Thắng there are resource issues, and that's somehow related to leadership and will to keep resources going for malaria, to get to malaria elimination. And also, I think it's an interesting point that you raise about behavior change for new tools. It's not just about the capacity of health workers, but convincing folks in the Ministry of Health themselves that new tools are necessary. I think that's something to bear in mind, because that also takes time to change people's minds. And from Dr. Siv, I think it's a good point that you highlight, you know, the health system only goes so far, and getting access at the community level is quite key. And Vivax is more complex. So if we have some of the new tools and they're feasible at the community level, that could help you get to elimination. Okay. I'm going to ask each of the panelists one more question each. I'm going to ask you guys to be relatively succinct so that we can hear from the audience as well, and questions they might have from you. But Leanne, for you, what do you see as the biggest challenges of introducing new tools along the pathway to patients, and maybe some solutions for new tools that are just emerging from the R&D pipeline in the next 3 to 5 years?
Thanks, Carrie. I mean, I guess I probably see the challenges in 2 different ways, or sort of split in terms of what's required to actually get them into country policy and implementation in terms of the regulatory process, you know, what countries need from a global perspective in terms of guidance from WHO, and how long that can sometimes take, which, you know, we've seen with some of the recent tools in terms of tefenoquine and G6PD diagnostics, which it's great we're so close, but this has taken a considerable amount of time, and countries, or certain countries, really are unable to move forward without that guidance. So I really think, you know, a major challenge is perhaps that dependence on global guidance, and some new tools potentially having very high relevance for certain countries or certain regions, and the potential that might exist for you know, layering of guidance and regional guidance that could really ensure, because, you know, I think we've heard from everybody that we actually don't, well, I don't think, what I've heard is, I don't think we want to be convincing programs, or, you know, that a new tool should be introduced. Rather, I want to hear, you know, like Dr. Siv, that there's a need for a new tool to add on to the active case detection that he and his program are already doing, that can identify hypnozoic carriers. And here there might be a tool, you know, shown to be a tool, and it's ready to expedite that process, you know, a little bit like what we talked about yesterday, or Simon talked about, you know, in terms of bringing azithromycin into the IDA combination, you know, the need was identified, the evidence was there, and then there needed to be sort of an expedited process, right, to make sure that WHO guidance can come through. And I mean, I think that's a major challenge that exists right across the board. And if there could be something that's more of a regional consideration around that, I think that would be great. Very briefly, I think the other major challenge are many of the ones that, you know, yourself, Dr. Thắng, Dr. Siv have touched on, and we've talked about almost the whole 1.5 days around the absolute need for health system strengthening. And to do that health system strengthening now with the existing tools we have, because we could be achieving more with those tools, and then if we're doing that, we're already going to be so much more ready to get the additional extra improvement out of any new tools that get slotted in. So I mean, I just think taking opportunities, in particular, if there is an opportunity, you know, for a country program to introduce a new tool, that's an opportunity for training, for ensuring robust training, supervision, support, which not only builds confidence in health workers themselves, that they actually have the tools they need to do their job well, but also in communities who suddenly feel like, well, in fact, I'm coming to the health facility and I'm getting a full course of treatment. That means I'm not going to be coming back in, you know, a month or 2 months' time. So I think a holistic approach around that could really solve some of those challenges.
Thank you very much. And for Doctors Thắng and Siv, from you, the two countries, I think you've been called out already, are really close to elimination. It's very exciting. I think we need to celebrate the fact that Cambodia has not seen a case of falciparum so far this year. They're incredibly close. And it's quite historic, given the situation in GMS just 15 years ago. I think your work has been profound. I would really like to hear from you as to what you think from your experiences in using new tools or using the current tools in health systems. What would you recommend to other countries that they should do to get as close as you are now?
Thank you for Carrie question. So, in order to reach the goal of malaria elimination, we need to combine many tools, many methods. On the way to get the new effective tool applied for malaria control and elimination activity. For myself, I think it's quite effective if all the new tools should be recommended by WHO. Because I saw in the Carrie presentations, it takes up to 5 years from the global strategy to the national application. So, for instance, if all the recommendations from the WHO, including the new tools, then for each single country, I think it's helpful to shorten the time in order to approach the new tools. I think for my experience, I think that's the first. And the second, we also think about the cost-benefit analysis. So we think about the cost, and we will compare with apply or without apply. And then in order to apply in larger scales, maybe some people, they still suspect about the feasibility and the impact of the new tool. then maybe the alternative, I mean the solution is we can do the pilot. Maybe we not immediately apply in larger scale, but we can apply in one commune, one district, or one province. So when people see in one pilot, it's very good impact and effective and easy. We can carry out in larger scale. So yeah, some my idea.
Okay, thank you very much. Everybody is know that we have committed to eliminate malaria, or this country like to do the word eradication by 2030. We don't have much time from now. If you do, like as Stan say, if you do the same, you will get the same result. And even the first section talking about Burnet use also disappointed. So we don't have time anyway. We need to use more robust tool. We need to accelerate our activity in order to reach our goal. We cannot use the same like that, and we don't expect to reach the goal if you use the same model like now. So new tool, yes, sure, we need it. But my idea is welcome to see idea from the robot malaria that we push it. Mean that we need to push everything as on track, or whether speed up. If you do like the same like that, we cannot achieve that. So for new tool that has been invented, each country has to implement depend on the scenario. Like African country, you are still in the control, not elimination yet, control program. So which tool that should be suited for control program? I think that the MDA is most likely is fit to the control program, because they are bring the burden quickly down to the low level. But we have some tool, new tool, that help you to what kind of tool that you can replace MDA while people is not very accepted, take drug while they are thinking that I'm not have a disease, so I take drug or something like that. Especially for Vivax radical cure, it's 7 days too long. So depend on each elimination country, which tool that you should implement it, use it. So, but however, I'm accepted that new tool very important. We cannot delay. Everybody have to, including global level, need to push it up. WHO need to speed up, and the donor need to be initiated. I give example of the GSPD test currently used in Cambodia. Even this test before 3 years ago. During that time, this test is not approved by WHO yet. But country need to do it. Otherwise, I cannot treat the Vivax in the country. We negotiate with Global Fund, saying to Global Fund, understand that this is a need of the country. So they just procure for Cambodia. But every procurement, I have to sign the letter of assurance with the Global Fund that this test is work, properly controlled, and no effect to the people. So we sign, every procurement is signed. Now it's something new, because there has been passed something. So we need to initiate something if the country need. Don't waiting for something that say, 5 years will be approved. So this is too late for your country. So this is very important. But I think that from now, everybody has in the room here know that how to commit it, how to push this speed up on this. Thank you very much.
Thank you very much. I think there's a clear message to listen to what the countries need, and each country use the tools that are fit for their own contexts, based obviously on the evidence. I also heard that from Leanne, perhaps considering, connected to that perhaps, more regional consideration as to be more specifically tailored to regional needs and country needs. Health system strengthening is obviously key, and looking at cost-benefit analysis as well. I've been told we can't go to Q&A, that we have to wrap up really quickly. So I'm going to very quickly pass the microphone to Dr. Lee to summarise the session. And for any of you that have got questions for the panellists, please do use any break time opportunity to have a chat to them. Thank you.
Yeah, thanks, Caroline. Nice to the leading of this session. At first time, the Kelley had give us some global insights for health systems. After that, Leanne gave us some new, introduced some new tools to us, and also third speech is Caroline. Also, that is a new tools is there. However, we'll try to the using that tools, because of the reason she gave us some pushing process for new tools. And also, Thắng and Steve as they give us some kind of challenge in their country and give us some kind of the success story to us, sharing to us. During this session, we already thinking the current challenges. We're thinking that one. So because of that kind of challenge, we will request the new tools. Maybe because the reason that somebody sees some researchers to make new tools. However, we meet another challenges. To using that kind of the tools, we met another challenge. That is another level of the challenges, I think. So, like as the Thắng and Steve mentioned, some kind of the legal process also some challenge, and financial and resource problem also another challenge to use the new tools to us. This kind of in this session we discussing very helpful, effectively use of malaria tools in each country. However, each country has their own health systems. So if there are some new tools, how to use that tools in your countries, you have to think. You have to make your own way to use that applicate that new tools in your country for malaria control and eradication. Yeah, this I hope this session is very helpful to all of the participants, and give back to your country and give have some big achievement for malaria control and elimination. Thank you, panelists, and thank you.